My name is Jessica Nguyen, and at 32, I thought I'd seen everything that could happen within the sterile walls of a hospital. As the privacy officer at Marble Falls Medical Center in Limestone Ridge, Texas, I'd spent the last 6 years ensuring our facility maintained the highest standards of patient confidentiality. Every morning, I'd badge into the administrative wing with the same sense of purpose that had driven me since graduating with my master's in health information management. Marble Falls Medical Center wasn't the largest hospital in Texas, but our 280-bed facility served the growing community of Limestone Ridge with pride. The morning sun would filter through the lobby's floor-to-ceiling windows, casting long shadows across the polished floors where families waited for news about their loved ones. I'd walk past the gift shop, the cafeteria's coffee aroma, mixing with the faint scent of disinfectant that seemed to permeate every healthcare facility. The first sign something was wrong came on a Tuesday in late September. I was reviewing our quarterly HIPAA compliance reports when Marcus Reed from IT knocked on my office door. His usually confident demeanor seemed strained as he handed me a printout of unusual system access logs. "Jessica, I'm seeing some odd patterns in our Epic system," he said, adjusting his glasses. "Someone's been accessing patient records outside their assigned units multiple times over the past month." I studied the timestamps and user IDs, my coffee growing cold as the implications settled in. The accesses were happening during night shifts, when fewer supervisors were around to notice irregular activity. Each entry showed proper authentication, but the pattern was troubling. Why would a step-down unit nurse need to view records from the emergency department and surgical floors? "Have you identified which employee?" I asked, though part of me already suspected the answer would complicate everything. "Natalie Reed from the step-down unit. She's been with us for 8 years, exemplary record. That's why I wanted to bring this to you first before escalating. Natalie Reed." I knew her well. We'd worked together on several patient privacy initiatives, and she'd been instrumental in helping me develop our current confidentiality training protocols. She was the kind of nurse who stayed late to comfort worried families, who remembered every patient's name long after they'd been discharged. The idea that she might be involved in unauthorized access seemed impossible. Over the next few days, I found myself paying closer attention to the subtle rhythms of our hospital. During my routine rounds through the units, I noticed things I'd previously overlooked. Conversations that stopped abruptly when I approached. Natalie's quick movements away from computer terminals when other staff members walked by. The way certain family members seemed to know more about their relatives' conditions than what should have been shared during official updates. The step-down unit, where patients recovered after intensive care but before returning home, had always been one of our most trusted departments. Families were often anxious during this transition period, desperate for any information about their loved one's progress. It would be easy for someone with access to provide unauthorized details, especially if they believed they were helping worried relatives. I began documenting everything: the unusual access patterns, the timing of family inquiries that seemed too specific, the subtle changes in departmental dynamics. Each piece felt like a betrayal of the trust I'd placed in a colleague I'd considered a friend. The breaking point came during a late evening shift change. I was finishing up some documentation when I overheard a conversation near the nurses' station. A family member was thanking someone for, quote, keeping them informed about things the doctors wouldn't tell them. The voice that responded, reassuring and familiar, made my stomach drop. As I sat in my office that night, staring at the growing file I realized that everything I thought I knew about maintaining trust and confidentiality in our hospital was about to be tested in ways I'd never imagined. The next morning brought an unusual request that would change everything. Dr. Marcus Reed, our chief medical officer, called me into his office with a concerned expression I'd rarely seen during our 5 years working together. "Jessica, we've received some concerning reports from families about information discrepancies," he said, sliding a folder across his desk. "Patients are mentioning details about their diagnoses that weren't part of their official discharge conversations. We need someone to investigate our privacy breach protocols." My heart sank as I opened the folder. 3 separate incident reports, all from the past month, all involving patients from the step-down unit. Families had somehow learned about test results, medication changes, and prognosis details that hadn't been officially communicated. The timing aligned perfectly with my recent observations. "I'm assigning you to lead this investigation," Dr. Reed continued. You'll have full access to our Epic system logs, badge entry records, and communication protocols. We need to identify how this information is being shared and by whom. As the hospital's privacy officer, I was responsible for privacy breach investigation procedures, but I'd never imagined I'd be investigating someone I trusted so completely. The weight of that responsibility felt heavier than usual as I returned to my office with the case files. The first incident involved Mrs. Patterson, an elderly woman recovering from cardiac surgery. Her daughter had called our patient relations department, confused about why her mother's discharge had been delayed. During the call, she mentioned specific details about her mother's ejection fraction numbers and medication adjustments that hadn't been discussed during family conferences. When questioned, she said one of the nurses had explained everything during a hallway conversation. The second case was even more troubling. A middle-aged man recovering from pneumonia had family members who knew about his oxygen saturation trends and antibiotic sensitivity results before his physician had reviewed them. They'd use this information to question treatment decisions during rounds, creating confusion among the medical team. The third incident was the most recent. A young mother recovering from complications after childbirth had relatives who somehow knew about her hemoglobin levels and the need for additional monitoring. They'd become increasingly anxious, demanding immediate answers from physicians who were still evaluating the situation. I spent the afternoon reviewing our Epic system access logs, cross-referencing badge entries with patient room visits. The data painted a clear picture that I desperately didn't want to see. Natalie's badge had been used to access patient records during off hours, often coinciding with family visits that weren't officially scheduled. The pattern was subtle but consistent. She would access patient charts in the evening, usually after the day shift physicians had left. Family members would then appear the next day with knowledge they shouldn't have possessed. The timing was too precise to be coincidental. I found myself walking past the step-down unit more frequently, observing interactions with fresh eyes. Natalie moved through her duties with the same competence I'd always admired, but now I noticed the quiet conversations with family members in empty hallways, the way she positioned herself near computer terminals when relatives were nearby. During one particularly difficult evening, I witnessed something that confirmed my worst fears. I was completing my rounds when I saw Natalie speaking quietly with the daughter of one of our cardiac patients. They stood near the family lounge, voices low but urgent. As I approached, I caught fragments of their conversation. The latest echo showed some improvement, but they're still concerned about the valve function, Natalie was saying. The cardiologist will probably want to discuss options tomorrow. The daughter nodded gratefully. Thank you for explaining this. The doctors never seem to have time to really talk to us. My chest tightened as I realized what I was witnessing. This patient's echo results hadn't been officially reviewed yet. The cardiologist was scheduled to interpret them the following morning. Natalie had accessed preliminary results and was sharing them with family members before the medical team had even seen them. I retreated to my office, hands shaking as I documented what I'd observed. The conso was becoming undeniable, but the personal cost felt overwhelming. Natalie wasn't just violating HIPAA regulations. She was betraying the trust of our entire medical team and potentially causing harm through premature disclosure of incomplete information. The investigation protocols required me to interview staff members who might have witnessed unauthorized information sharing. I started with Marcus Thompson, one of our most experienced charge nurses, who worked closely with the step-down unit. I've noticed some unusual patterns, he admitted when I asked about information flow to families. Sometimes relatives know things they shouldn't, and it's creating during rounds. Physicians are being questioned about results they haven't reviewed yet. Have you observed any specific incidents? I asked, though I dreaded his answer. Marcus hesitated before responding. I've seen Natalie having detailed conversations with families during shift changes. I assumed she was providing emotional support, but some of the discussions seemed clinical, more detailed than what we typically share. Each interview revealed similar observations. Staff members had noticed the pattern, but hadn't connected it to a systematic privacy violation. They trusted Natalie's judgment and assumed her interactions with families were within appropriate boundaries. The final piece came from our IT security logs. Natalie had been accessing patient records from multiple units, not just her assigned step-down patients. She was reviewing charts for patients whose families had specifically requested more information during visiting hours. The scope of the breach was far larger than I'd initially suspected. As I compiled my findings, I realized that Natalie had been systematically violating patient privacy for months, possibly longer. She'd built relationships with worried families, positioning herself as someone who could provide the detailed information they craved. Her genuine compassion had been twisted into something that violated every principle of medical confidentiality. The hardest part was understanding her motivation. Natalie truly cared about her patients and their families. She'd seen their anxiety and frustration with the sometimes slow pace of official communication. In her mind, she was probably helping, providing comfort and clarity during difficult times. But her good intentions had led to serious ethical violations that could have devastating consequences for our hospital and our patients. I sat in my office late that evening, staring at the completed investigation report. Tomorrow, I would have to present my findings to Dr. Reed and recommend disciplinary action against someone I'd considered a trusted colleague and friend. The pause was clear, the violations were serious, and my responsibility as privacy officer left me no choice. The silence in the hospital felt different now, heavy with the weight of broken trust and the knowledge that nothing would ever be quite the same. The next morning arrived with the weight of inevitability. I'd barely slept, rehearsing how to present my findings to Dr. Reed while maintaining the professional composure my position demanded. The investigation report sat in a sealed envelope on my desk, each page documenting the systematic privacy violations that would Natalie's career at Marble Falls Medical Center. Dr. Reed's office felt smaller than usual as I laid out the IT logs, the interview summaries, the documented instances of unauthorized disclosure. He listened without interruption, his expression growing more serious with each revelation. "How many patients were affected?" he asked finally. "At least 47 that we can document. Potentially more." The number felt heavy in the air between us. "The violation spanned 6 months, possibly longer." Dr. Reed leaned back in his chair, processing the scope of the breach. "And you're certain about the source?" "The is conclusive. Natalie accessed records outside her assigned unit, shared specific diagnostic information with family members who weren't authorized to receive it, and did so repeatedly despite clear protocols." He nodded slowly. "We'll need to involve HR immediately. This level of violation requires immediate suspension pending a formal disciplinary hearing." The administrative machinery moved swiftly once set in motion. Within hours, Natalie was called to HR for what she assumed was a routine meeting. I wasn't present for that conversation, but Marcus Chen found me in the privacy office afterward, his expression grim. "She's been suspended," he said quietly. "Effective immediately. Badge access revoked pending the formal hearing." I felt no satisfaction in the news, only a hollow sense of duty fulfilled. How did she take it? She was shocked, kept insisting she was only trying to help families understand their loved ones' conditions better. Marcus sat down across from my desk. "She asked specifically to speak with you." The request didn't surprise me, but it complicated everything. As the investigating officer, I needed to maintain professional boundaries. Yet part of me wanted to understand how someone I'd trusted so completely had rationalized such clear violations. "I can't meet with her directly while the investigation is active," I said. "It wouldn't be appropriate." Marcus nodded. "I figured as much." "But Jessica, there's something else." Word is spreading through the units. Staff are asking questions about what happened, why Natalie was suddenly escorted out. This was the part of privacy investigations that extended beyond the immediate violation. Hospital staff needed to understand that confidentiality breaches had serious consequences, but we also couldn't create an atmosphere of paranoia or mistrust. The balance was delicate. "We'll need to address this carefully," I said. A general reminder about privacy protocols without discussing specifics of the case. Over the following days, the formal disciplinary process unfolded with bureaucratic precision. The hospital's legal team reviewed my findings, HR conducted their own interviews, and the compliance committee prepared for Natalie's hearing. Throughout it all, I maintained my role as the investigating officer, providing additional documentation when requested, and clarifying details about the privacy violations. The most difficult moment came when I had to testify at the formal hearing. Natalie sat across the conference room table, flanked by her union representative and looking smaller than I'd ever seen her. When our eyes met, I saw confusion and hurt, as if she still couldn't understand how her actions had led to this moment. Ms. Nguyen, the hearing officer began, please walk us through your investigation findings. I presented them methodically, keeping my voice steady and professional. The IT logs showing unauthorized access. The documented instances of information sharing. The pattern of violations that had continued despite clear protocols and training. Natalie's representative tried to argue that her actions were motivated by compassion, that she'd been trying to provide comfort to worried families during difficult times. They emphasized her years of dedicated service, her excellent patient care ratings, her genuine concern for those under her care. But good intentions couldn't excuse systematic privacy violations. The hearing officer asked pointed questions about hospital policy, about the training Natalie had received, about the clear boundaries that existed between appropriate family communication and unauthorized disclosure of medical information. When given the opportunity to speak, Natalie's voice was barely above a whisper. I never meant to hurt anyone. I just wanted to help families understand what was happening. They were so scared, so confused by the medical terminology. I thought I was making things better. The sincerity in her voice was unmistakable, which somehow made the situation more tragic. She genuinely believed she'd been helping, but her actions had created legal liability for the hospital and violated the fundamental trust patients placed in our institution. The hearing concluded with a recommendation for immediate termination. Natalie's nursing license would be reported to the state board for review, and she would be barred from future employment at any facility within our health system. As the room emptied, Marcus approached me in the hallway. That couldn't have been easy, he said. It wasn't, I admitted, but it was necessary. He nodded. The staff are asking when we'll get an update about privacy protocols. They want to make sure they understand the boundaries clearly. This was exactly the kind of response I'd hoped for. Rather than creating fear, the investigation had prompted genuine interest in understanding proper procedures. I'll schedule training sessions for each unit over the next 2 weeks. We'll review the policies and answer any questions they have. The training sessions were well attended and productive. Staff members asked thoughtful questions about appropriate family communication, about how to balance compassion with confidentiality requirements, about the proper channels for addressing family concerns. The conversations were exactly what our hospital culture needed. During one session, a newer nurse raised her hand. What if a family member asks for information that seems reasonable but isn't technically authorized? How do we handle that compassionately? It was a perfect question that got to the heart of the ethical challenge. We acknowledge their concern and direct them to the appropriate channels, I explained. We can offer to have their loved one's primary physician call them, or help them understand the formal process for accessing medical information. Compassion doesn't require violating policy. 3 weeks after Natalie's termination, I received a call from the state nursing board. They were conducting their own investigation and needed copies of our findings. The process would continue beyond our hospital's walls, but my role in the immediate investigation was complete. The step-down unit had adjusted to Natalie's absence with the resilience that healthcare teams develop out of necessity. A temporary nurse had been assigned, and the unit's operations continued smoothly. The families who had grown accustomed to Natalie's unauthorized updates had been gently redirected to appropriate communication channels. Most importantly, the investigation had strengthened our privacy culture rather than damaging it. Staff members were more aware of boundaries, more likely to ask questions when uncertain, and more committed to protecting patient confidentiality. The painful process had ultimately made us better at our fundamental mission. As I filed the final paperwork from the investigation, I reflected on the complexity of healthcare ethics. Natalie's violations had been serious and systematic, requiring decisive action, but they'd also emerged from genuine compassion, from a desire to help families navigate frightening medical situations. The tragedy wasn't just in her actions, but in how good intentions had been channeled in destructive directions. The investigation was officially closed, but its impact would continue shaping our hospital's culture for years to come. 8 months later, I stood in the conference room at Cedar Valley Regional Hospital, watching a group of new nurses take notes as I clicked through my presentation on patient privacy protocols. The morning sun streamed through the windows, illuminating faces that reminded me of my younger self, eager, dedicated, and perhaps not yet fully aware of how complex healthcare ethics could become. Patient confidentiality isn't just about following rules, I explained. advancing to a slide showing proper documentation procedures. It's about maintaining the sacred trust that allows healing to happen. When that trust is broken, it affects everyone: patients, families, and the entire healthcare team. My new role as privacy compliance coordinator at Cedar Valley had emerged from the painful lessons learned at Marble Falls Medical Center. After Natalie's termination and the subsequent investigation, I'd realized that my true calling lay in preventing such violations before they occurred. The position allowed me to combine my clinical background with a passion for protecting patient rights. Now, let's discuss proper disposal of confidential patient documents, I continued, pulling up the next section. The irony wasn't lost on me. I trained staff on proper disposal of confidential patient documents, among other critical privacy procedures. Every shredded paper, every secured computer terminal, every careful conversation represented a small victory in maintaining the trust patients placed in us. The investigation at Marble Falls had concluded with Natalie's nursing license being suspended for 2 years. The state board's review had been thorough, examining not just the specific violations but the pattern of boundary crossings that had enabled them. She'd been required to complete additional ethics training before any possibility of reinstatement, though I'd heard through professional networks that she'd chosen to leave healthcare entirely. Marcus Reed, my former ally in the investigation, had been promoted to Assistant Director of Nursing at Marble Falls. He'd called me last month to share how the unit had transformed its approach to family communication, implementing structured updates and clear documentation protocols. The painful experience had ultimately strengthened their privacy culture. During my lunch break, I walked through Cedar Valley's corridors, observing the careful dance of healthcare professionals going about their duties. Badge access systems beeped softly as staff moved between units. Computer screens locked automatically when left unattended. Conversations about patients occurred in appropriate spaces, away from public areas. These small details, invisible to most visitors, represented the infrastructure of trust that made healthcare possible. Every protocol followed, every boundary respected, every confidence maintained contributed to an environment where patients could focus on healing rather than worrying about their privacy. The weight of the Marble Falls investigation had lifted gradually over these months. The sleepless nights, the difficult conversations, the moral complexity of holding a colleague accountable, all of it had settled into a quiet confidence in the importance of the work we did. Healthcare required both compassion and boundaries, both flexibility and firm ethical standards. As I prepared for my afternoon training session with the pharmacy staff, I reflected on how the experience had changed my understanding of professional responsibility. Betrayal in healthcare wasn't always dramatic or obvious. Sometimes it emerged from small compromises, from good intentions poorly executed, from the gradual erosion of boundaries that seemed insignificant until they weren't. My phone buzzed with a text from a former colleague at Marble Falls, sharing news that their latest privacy audit had received the highest possible rating. The systems we'd strengthened during the investigation continued protecting patients months later. The painful process had created lasting positive change. The afternoon training session focused on recognizing and reporting potential privacy violations. I watched the pharmacy staff engage seriously with scenarios that might have seemed theoretical before my experience with Natalie. Their questions were thoughtful, their commitment genuine. Remember, I concluded the session, protecting patient privacy isn't about being suspicious of colleagues or creating barriers to compassionate care. It's about creating structures that allow trust to flourish safely. As the staff filed out, discussing the training among themselves, I felt the deep satisfaction that came from meaningful work. The investigation at Marble Falls had been one of the most challenging experiences of my career, but it had led me to exactly where I needed to be. The evening drive home took me past the medical district where I'd spent so many years. The lights in hospital windows represented thousands of individual stories: patients seeking healing, families hoping for good news, healthcare workers dedicating their lives to serving others. All of it depended on the delicate foundation of trust that privacy protections helped maintain. At home, I reviewed my notes for tomorrow's presentation to the hospital board about expanding privacy training programs. The work continued, each day bringing new opportunities to strengthen the ethical foundation of healthcare. The investigation that had once felt overwhelming had become the cornerstone of a career dedicated to protecting what mattered most. The silence of my home office, free from the weight of unresolved ethical dilemmas, felt different now than it had during those difficult months. It was finally over. And the silence felt earned,